It's my honor to welcome you to the Agency for Healthcare Research and Quality, an independent science agency in the U.S. Department of Health and Human Services. It's my honor to welcome you here today for our 35th anniversary summit, AHRQ at 35, Reflections and Futures in Health Services Research. I'm looking forward to learning from the experts we have lined up today. But first, I would like to introduce our expert moderator, Dr. Edmundo Robinson. Dr. Robinson is founder and chief executive officer of Downton East Digital and professor in the Morsani College of Medicine at the University of South Florida. Dr. Robinson, the summit is yours.
Thank you, Sean. Appreciate it. Welcome, everyone. Really excited to be here. We're going to have some fun. We're going to learn some things, and we've got a really great group of folks that are going to be part of these conversations. But let's start with housekeeping, right? So as noted on the slide here, the session will be recorded. Your video participation is encouraged, so try to stay on with video on as you can. Keep your line muted when you're not speaking. And in terms of engagement, most of the questions or comments that you might have, put them in the chat. We are tracking the chat real time, and I will pull out questions out of the chat as we go through the conversations. There will be a couple of sessions where we will open it up for verbal questions. And so when we do that, use the raise hand function. When you do that, when you hit your raise hand function on Zoom, it puts you in order, right? So it's kind of first hand, first come, first serve type of thing. So do it. Go ahead and use the raise hand function, and then I'll pull from each of those folks. I think yes, and then the rest of it is, you've got a link here for additional resources, and please remember to follow and use the hashtag for AHRQ and follow AHRQ News on social media. So with those points, actually, there's also one of the you should have gotten ahead of time for all the attendees. You should have gotten ahead of time that speaker bios and all those. So when we do introduce speakers, we won't go deep into their bio. We will introduce them pretty superficially. You can definitely go and read their bios. Everyone who's speaking has a long bio. So we will introduce them. You can go and double click into their bios as you have the information that was sent to you ahead of time. Let's see the next slide here. Awesome. So I'm really excited to introduce these two folks. As AHRQ approaches its 35th year, this is an opportunity to pause and reflect on the history and impact of health services research, and to imagine the various kind of futures that may present themselves in the next 35 years, right? So it's a bit of a retrospective, but we want to be very prospective about these conversations as well. To that end, I want to introduce here our first session, which is, again, a fireside chat here between Dr. Robert Valdez, the director of AHRQ, as well as Dr. Erin Carroll, president and CEO of Academy Health. With that, Dr. Valdez, the floor is yours.
Great. Thank you very much, Edmundo. I'm very pleased to welcome everyone for today's discussion and celebration of AHRQ at 35, Reflections and Futures in Health Services Research. Now, health services research provides the foundation for medical progress, effectiveness, and the value in healthcare. This is really an opportunity for us to reflect on past achievements and identify some challenges that we're currently facing, and to really establish a future priorities for where we think healthcare ought to be I like to say in the 24th century, because we're going to be planting some seeds. But at least in the future of the far end of the 21st century, if not the 22nd. This year, we commemorate the 35th anniversary of AHRQ's elevation to full agency status. 35 years ago, Congress had the wisdom to create AHRQ as an independent science agency, joining our colleagues at NIH and FDA and CDC. It's a pivotal moment in which health services research was recognized as a fundamental component of healthcare and a key to improving healthcare delivery. Um, at the beginning of those areas, we have two people who played large roles during that period of time, who were major figures in our community that I'd like to recognize that we lost this last year. Jarrett Clinton, who was the first director of AHRQ, and Jack Wenberg, who was a leading health services researcher at Dartmouth, and who brought us great insights about practice variation. You know, health services research, as everyone knows, is a multidisciplinary and collaborative field, really a field of study and inquiry that's focused on real world settings and the ability to find solutions to improve care delivery along the 6 domains of quality: safety, effectiveness, patient-centered, timely, efficient, and equitable. It addresses that broad set of topics of medical knowledge, care delivery processes, organization, and financing of services. When Congress elevated the National Center for Health Services Research and Technology Assessment, it recognized that in order to make medical progress, 3 lines of inquiry had to be intertwined. The fine work that was being done and is being done in biological and biomedical discovery. But it also required us to look at how new technologies could be introduced into medical practices and procedures, such things as the things that we're trying to deal with today, the new generative artificial intelligence. But in the 1960s, we were already introducing artificial intelligence. So these challenges of new technologies or new materials remain part of our work. And of course, health services research, the effort to really try to understand how care is organized, delivered, and financed in a better way to serve the needs of a aging and more diversifying population. AHRQ's had a great history over the last 35 years. It's had some major achievements. AHRQ's data collection and analysis initiatives inform our understanding of consumers' use of healthcare, their experience in seeking healthcare. The Medical Expenditure Panel Survey is the nation's most complete data source for healthcare costs and use, and I'm sure many of you use it. The Healthcare Cost and Utilization Project provides the most extensive longitudinal data on hospital care, and that's certainly used by states and others around the country. Team STEPS was developed in partnership with the Department of Defense. It's a team training curriculum used by healthcare organizations since 2005 to guide hundreds of thousands of professionals in evidence-based patient safety practices. It's been adopted by over 125 countries and is used extensively throughout the country. Since 2001, the agency's Evidence-Based Practice Center program has developed more than 800 reports summarizing the evidence on medications, devices, and other services. Today, we have an opportunity to hear from our partners and stakeholders and ponder a future filled with innovation and collaboration that can truly transform care in our nation to one that is equitable and person-centered. For more than 35 years, Academy Health in its various guises and AHRQ have both been working together to support the best and brightest in health services research to achieve that future improvement that we all seek for our patients, for our healthcare organizations. And I'm really very happy that Dr. Erin Carroll, President and CEO of Academy Health, is joining us today for this discussion. It's only fitting that we start this discussion on the future of health services research with a conversation with the public and private sides of the health services research coin. Erin, thinking of the histories of AHRQ and Academy Health, what stands out in your memory as a strength of health services research, and how do we push into the future?
Well, first of all, let me just say congratulations on 35 years, and it's an honor to be here. But I mean, health services research is what gives us the ability to look at the true effectiveness of care, not just whether it has efficacy. And even the most well-designed randomized controlled trials really only get at how do these things work for the most part in very controlled settings. But the HSR as a discipline is what actually looks at whether care works, how it's financed, organized, delivered, and therefore, how good is it in actually improving the health and lives of Americans and beyond. But it still has a ways to go. I think that too often we keep pointing out what's wrong without offering perhaps good solutions. We're really good at telling you what's not working with the healthcare system. We're not as good at telling you what to do about it. And if I had to think of one thing I really think that we need to really push on in moving into the future, it's finding new methodologies, finding new ways of doing the research, finding new ways of communicating the research so that we get at how do we take actionable steps to make things better and not just pointing out where things are not working well.
Yes, Aaron, I agree with you. As you know, here at AHRQ, I've been pushing us to sort of return to our roots. The founders of health services research were really seeking a scientific basis for clinical interventions. And not only that, but we've pushed into evidence-based medicine as that sort of field. We've done probably less on trying to create the evidence for truly making the management of organizations more efficient in the service industry that we occupy. And oftentimes we really need to determine whether interventions do more good than they cause harm. So I think we've got to get back to the roots of our field, being an applied R&D part of the industry, because the industry at this point really operates on very slim margins, and so there's very little that people can do. Healthcare executives that I talk to, however, see research as a bad word.
Yeah.
R&D hasn't really been part of the equation in the last decade or so, despite the fact that many of our early leaders like John Griffith, who was a health manager, really recognized and worked with many of the other founders of health services research in the 60s to try to bring evidence for management purposes. And that's a curiosity. How does our field look from your perspective with regard to actual implementation work?
Well, part of that is actually, I think, a real communications problem. I think that too few people in the world even know what health services research is, and let alone understand why we might need more of it and why we need to make use of it. I don't think that we have done the best job we could explaining to people why the great body of work that has been done through the work of health services researchers has application and how we can use it. And again, that gets back to I think the solutions versus problems, side of the coin, in that we keep telling everyone what doesn't work, which can get frustrating after a long period of time if it doesn't pivot to giving them actionable things that they could do to make things better. In addition, I'm not sure that we have done the outreach we need to the many aspects of the healthcare system which are necessary in order to enact real change. This includes patients, although I'd argue, we've made great strides there and patient engagement has moved forward quite a bit. But we don't engage policymakers enough as we should. We don't engage healthcare system leaders as much as we should. We don't engage too many people outside of academia in understanding how to implement this work and how to take it the final step of the way so that it does good. Part of this is because I think we just haven't figured out the methodology or the means by which we can take that final step. I think in many areas of basic science and even clinical science, we rely on the fact that once we get to a certain level of knowledge or discovery, that private industry in some ways will take over and move it the rest of the way, create the drug and market it, create the device and market it, do whatever else change might be necessary. But with health services research, that's much harder, because once we even have the solution, there is no sort of industry ready-made to pick it up and run. And so a lot of the good work, even in interventional work that I think we do in health services research, unfortunately dies in the vine because we haven't figured out the way to move it the final distance. And we're going to need to have better partnerships and think about new and innovative ways to do that if the changes and the improvements that we see through our work really make it into everyday practice.
Well, I'm excited about an initiative that we're doing in partnership with PCORI, our sister agency in the Patient-Centered Trust Fund Research Trust Fund, really looking at how we create those kind of infrastructures that are necessary for implementing health services research more rapidly once innovations are made. The PCORI grants are focusing at the micro level at the organizations. Here at AHRQ, we're looking at, we've just launched the Healthcare Extension Service, taking the cue from the Department of Agriculture that moved innovative science into farming and increased productivity tremendously and quality tremendously. And it's intended to deal with the social political aspects of care in the industry so that the various players in the ecosystem, of which there are many and are varied from state to state, have really a place at the table to begin to align the incentives as well as reduce the fragmentation. Are there other ideas that you have about how we could improve or speed up the handoff of research to implementation?
Well, I think part of it is even in the ways that we fund research. I think that it's still, even in health services research, we use a very basic science model, but we don't go all the way. Much of our investigator-initiated work cannot be renewed. In fact, I've never had an R01 renewed, but a lot of labs, do 3 to 5 years of work and then apply and get renewed and renewed and renewed. That allows other parts of the NIH to invest in labs and people and long-term projects more than what we're able to do in health services research. So instead of, I think, investing in, big, bold change that can take place over a long period of time, we wind up with a lot of one-off projects, which unfortunately then don't stick because the infrastructure that's needed and given in funding isn't long enough or broad enough to really get the last mile to where we're actually going to make change. In addition, our work is very different. There's not a lot of equipment. There's not a lot of lab space or investing in things. It's people, and it's much harder to invest in people and then have them stick around once a grant ends, while a lot of equipment might. It's also hard to fund various aspects that we know are important, but not part of the traditional research focus that when people think of research. Community engagement is incredibly hard and takes a long time and is very hard to fund. Engagement in health systems change. Doing change management, very hard, takes a long time, very hard to fund. Even doing, I think, a lot of the work that's required for outreach or implementation science or for communication. Again, these are things we know are critical to making the research that we do permeate and then stick, but it's very hard to do it, and it's very hard to get it funded. And if anything, we always seem to be asking everyone to do more with less, which is hard.
Well, Aaron, I completely agree with you. We need a different way to conduct research in health services research. And certainly we have migrated to adopting the sort of lab model of research funding, but not the extended lab research. I started my science work in a biochemistry lab, and my boss, Professor Nishimura, had been working for decades on this same acetokinase issue from grant to grant to grant. But we certainly haven't been able to do that in health services research, although we've often taken on this idea of a lab in trying to sell our work because it is science-based, except that we are different. Trying to work in the real world really requires us to think differently about how we conduct research, the tools that are available to us for us to do with the research, the rapidity at which we need to do the research. it's clearly an area that is a challenge, and that's certainly something that we're trying to take on here at AHRQ as we rethink how we support and motivate research projects in the real world. I want to switch tact a little, switch lanes right now. We get a lot of push right now around how do you take these new technologies like generative AI and how do you make sure that they're timely and safe? Is that really how we should be thinking? Do you have a sense of sort of how we move the field forward without getting trapped into what's today's issue and problem as opposed to thinking about tomorrow's issues and problems?
Well, I think it's a combination. I think part of the thing we need to get better at is being a little bit more nimble and being able to move a bit quicker when we recognize that something like artificial intelligence is happening as we speak, and we need to really study it. I always think back to when I was a new health services researcher. My interest and focus was on how we have all these electronic medical records, and everyone is starting to use electronic health records. And is anyone studying that to see if it does harm as well as good, and how they might be used? And I remember when I used to pitch this when I was a clinical scholar, I would get very strange glances like, that doesn't seem like something we need to work on. And I feel like nothing, everything is repeating itself. Artificial intelligence is here and it is being used. And if we don't really embrace it and start bringing our talents and methodologies to bear to study it, we're going to miss our opportunity. And it's not going to be a couple-year thing. It's likely going to radically change how so much of health and healthcare is done. But there's the potential for harm if it's not used correctly. And we have to look at both sides of the coin, not just assume, as we often did with EHRs, that it's an unequivocal good and we therefore should deploy and use, and we'll figure out what happens later. We really do need to make sure that there aren't unintended consequences, that biases don't fit in, that algorithms aren't following perverse incentives and really making things in some ways more difficult than it used to be. But I think we also have to be a little bit quicker and more nimble in how we adapt these technologies even to our work in HSR. There's just so much amazing potential to use bigger, broader data sets with the use of AI. There's the potential for AI to address areas of interoperability or match up data in data sets that don't necessarily line up to require less in the way of standardization if we can figure out ways for AI to, in real time, figure out how data should link up. They're just, and that's just a few of the ways. But we need to think exactly as you're saying about the future and the long term, not just like, what am I going to do with this today, but how might it be used, and therefore really get into the work of both using it in the ways that we need to, and really making sure that we're there to study and advise people on how to use it best.
As I talk to my colleagues and many of my mentees who actually run health systems, as cost increases really force them to make a lot of decisions, it's real clear that we need real-time, rigorous assessments of quality, costs, and outcomes. And this becomes increasingly a challenge and for us as health services researchers, as the complexity of care and care delivery increasingly becomes more complex. First of all, because we have an aging and more diverse population, and also the vast innovations that have occurred in our understanding of the genome and genetic potentials for more and earlier intervention therapies. We really need to embed our effectiveness insights and evidence generation directly into the care delivery process so that we're not studying something that happened yesterday and providing insights from yesterday, but actually helping people make decisions today and for tomorrow. How do we do that?
Well, I couldn't agree more. And I think part of what you're describing is what we've all hoped the learning health system would eventually help us get to. But I think it goes so much further than that. You're talking about how do we embed our discoveries into actual care? Like, we need an infrastructure. We really need some innovative models and some way to distribute the findings that we discover into where care is actually happening. That includes public health. That includes, that includes doctors' offices. That includes hospitals. That includes, where healthcare is delivered, as well as thinking about community organizations and other means by which health is improved that we've missed. And again, part of that is I think we need to figure out ways to do it. We need to figure out ways to fund it. We need to figure out ways to reorganize. All of that is not easy. Changing the system is very hard. We've spent, the last few decades arguing about, at a national level about how we fund insurance for a relatively small percentage of Americans. And we have fought hard about that over the last few decades. What we're talking about here is really getting into system delivery, how we provide care, looking at quality. Those are much harder, and they will require significant amounts of time, focus, effort, and resources. But that's where the magic is going to happen. And that's where I think, and that's why I'm still so excited about health services research and the future, because there is just so much potential for improvement and so much hard work to be done. But I don't think health services researchers have ever been afraid of that. They just want the tools and the ability to go out and do that hard work.
Yeah, and you and I have talked about this in the past, and I know that many of my colleagues don't like me saying this, but health services research, like much of health research, has been captured by the academic enterprise that has created different incentives for the health services research community, often moving them away from the problem-solving applied health services research that you and I have been talking about, to really an incentive for simply volume. How many publications can you generate, and how many grants can you bring in?
Right.
In part because many of us have to fund our own salaries through the grants that we bring in. That kind of being eaten up by the academic enterprise has really created barriers, I think, for people who want to make change in care delivery and in improving care, which was the focus of much of our historical leaders and founders of health services research. When time was perhaps a little easier, or you had a fully funded professorship and you could pursue those kinds of impactful projects. We're running out of time, so I want to give you an opportunity to offer some final reflections or words of guidance for the upcoming generation of health services researchers. We're going to try to take up today some of the questions that you and I have raised about how we make change in health services research and how we make the future of health services research more impactful. But I want to give you the final word here.
I appreciate that. And I mean, I think the big message I would want to get across is that I think we have to get away. We've often in research been told, find your niche, hone down as small as possible. And that might work, I think, in a basic science career. But I think we have to really broaden our scope. I think we need to start focusing more on the end, the end users, patients, health systems leaders, people who work in health systems, figure out what are the major issues that are preventing us from getting from where we need to be, and then working backwards to say, knowing that that's where we want to end up and the problem we want to solve, how best do we solve it? Who would be best to solve it? And what steps do we need to take to get there? I think too often we're going in the opposite direction. As academics, we look at what RFAs are out there. We try to figure out what of our work will fit the funding. We make a small addition to what's going on. And that works in many ways, but it doesn't get to that end solution that we really desperately need. And if there's some way to really work on true innovation in the ways that we do the work that we do, in order to better solve the problems that we all know are there, I think we'll see a lot more success.
Thank you, Aaron. And I agree with you. We also need to generate evidence for managing better organizations and systems. Certainly our healthcare leaders are looking for that. And there's an opportunity and opening for us to really contribute to evidence-based management and not just evidence-based medicine.
I agree.
think we've got a lot of work to do. So I'm going to turn this over to Edmundo, who is ready to launch forward to help us find some solutions if we actually begin to make this change.
Thank you.
Thank you both. So thanks to Dr. Valdez and Dr. Carroll. Really fascinating conversation, and I remember it's funny that you mentioned, Bob, the idea of the evidence-based management. That was when I was a clinical scholar at Penn. That was actually my thesis, which was around how do you bake in evidence into managing these complex health systems. So spot on. One of the other things I heard, and I a lot in this conversation. I think a really great way to kick off the day. One of the other things I heard though was also that we we have to figure out how do we engage the people in this process, maybe outside of academia, maybe outside of that kind of structure, but there's a lot of other folks here that need to be engaged if we're really going to be effective. And so as I was reading and exploring our next speaker, I think that he's really going to bring some of that perspective. And so I think it's a really nice segue from this conversation, from this fireside chat into the next conversation. So with that, I'd like to introduce Dr. Brent Oliver. He's System Vice President for Care Experience at the Value Institute at Dartmouth Health and Associate Professor, Departments of Community and Family Medicine, Psychiatry, and the Dartmouth Institute, Geisel School of Medicine at Dartmouth. Dr. Oliver, look, I'm going to just hand it over to you and let you take it from here.
Thank you very much, and it's an honor to be here at your 35th anniversary summit and to serve as the keynote speaker and to talk about a perspective that might be helpful to include as we think about the future. And my brief remarks today will be centered around a call to include the improvement of human experience in the future of health services research. Next slide, please. I have no real or potential conflicts to report related to this presentation. Next slide, please. I've organized my remarks around two central elements. The first is the agenda of today's meeting. I'm hoping that the comments I share today, at least some of which will be helpful as we go into the afternoon sessions. And the second was based on this editorial that framed a recent series on improving human experience in healthcare. And I've organized today's talk around these 5 elements on the left. The first of which will take us back in time a little bit and help for framing, and then the remainder which will move us forward. Next, and also before we go to the next slide, I put links and references throughout for more detailed look into the things I'll mention. My comments are brief today, so I won't be able to go into full detail on some of the things I'll discuss. So please use the links to read more if you're interested. Next slide, please. I'm going to start by looking back. I call this a tale of two trajectories. During the planning meeting, I was talking with the AHRQ team and talking about my history a bit. And they said, you should talk a little bit about your history. And I said, well, and align it with AHRQ. And I really enjoyed doing that. I learned a lot about AHRQ's history, reviewing the historical timeline on the website. And I've matched it with a few of my smaller milestones along the way to show how AHRQ has influenced my life and career. So here we are in 1990 when I graduated high school. AHRQ was called AHCPR at the time, and they were just starting the study of practice variation. And I was really thrilled to hear Dr. Wenberg mentioned at the beginning of the session today. He was turned out to be one of the figures when I studied at Dartmouth that so inspired me to get into this field. And the idea of small area variation was just captivated me as I started my graduate studies later on in my career. By 1995, when the U.S. Preventive Services Task Force joined AHCPR and started issuing guidelines around prevention, I was just leaving college and moving into my first health services career as an outreach social worker, working in impoverished inner city environments with severe mental illness populations. And I learned quite a bit just firsthand about what we now call social and behavioral determinants of health in that work. By 2003, I'd completed my first graduate degree and was entering practice as a nurse practitioner, dual certified in family and psychiatric practice, embedded in medical homes. To try and bring psychiatric care into primary care settings and primary care into psychiatric settings. And this was right around the time that the National Healthcare Quality and Disparities reports were coming out. In 2008, when the roadmap to prevent HAIs and comparative effectiveness research was a big focus and being launched, I was just completing my public health degree, and I had met and studied with people like Batalden and Nelson and Fisher, and I was completely captivated with this idea that healthcare could be improved, systems could be understood, and especially this idea of a learning health system really captivated me. And I moved into a PhD in health services research focused in these improvement areas. Around 2012, when I completed my doctoral and fellowship training, the Quality Indicators Toolkit for Hospitals was coming out, and I was starting as a brand new academic. And fast forward 2022, I was really impressed to hear about how we're thinking about how we can create a better way to do health services research and perhaps focus on the management of healthcare as one of the things we need to do. I actually took a big risk in my career by becoming a senior leader in the health system and am working as an embedded learning health system scientist in that capacity to see if we can create capability within our own health system that is ready and more flexible and capable to do research and translate it to practice more efficiently. Interesting note is that I started during the pandemic, right around the time AHRQ was launching its massive long COVID campaign. At the time, I was working locally to set up our long COVID clinic and currently working as one of a number of faculty educating the next generation of learning health system scientists as part of an AHRQ and Bakori funded award. So I just want to congratulate AHRQ on its 35-year history, only a part of which is shown here, and also to recognize how influential AHRQ's work has been on my small little career in the middle of it as an individual. So thank you, and it's wonderful to be here. I'd like to move to the next slide with one more historical framing approach, of which there are many, but I like this one because it from Batalden and Foster, because it gets into thinking about quality from a developmental perspective, and they comment on the development of the field over the past century. And from their perspective, they organize it into three developmental steps, which aren't mutually exclusive, but they kind of build upon each other. And they call it 1.0, 2.0, and 3.0. And 1.0 gets a lot into this issue of developing standards and thresholds and accreditation and guidelines, critical foundational elements for establishing evidence-based quality standards. Quality 2.0 gets into the idea of the systems applications and the mechanistic aspects of quality and improvement. Things like systems science, healthcare delivery science, high reliability, and mechanistic approaches to process improvement like Lean Six Sigma and other improvement approaches. And Quality 3.0, they argue, is the next wave where improvement in quality will become more humanistic. I'm so encouraged to hear us talking about the need to invest in people and that healthcare is really about how we can help people. The co-production approach argued in 3.0 is one frame that might make quality and its improvement much more humanistic and relational. So next slide, please. I'm now going to move us to thinking about the future, building on those framing pieces. And I called this emerging and converging because I think these are things that are emerging as important and that they may also converge with each other in the developing future, if not already. Next slide, please. The first, of course, is co-production of healthcare service, which I previously touched upon. And Batalden and colleagues' discussion of this really challenges us in a fundamental way. Our traditional mechanism for understanding healthcare is as a delivery of product. A professional delivers a product or a treatment to a patient, and so on. Co-production challenges this by reframing it as a relational entity where healthcare is co-created between an interaction with professionals and patients, each of which bring an area of expertise to the encounter. This may seem like a subtle frame shift, but if we think about it, it changes the game in terms of how we might think about conceptualizing, measuring, evaluating healthcare, and what value might mean. Next slide, please. Studies like co-value are trying to figure this out because co-production has quite a bit of promise conceptually, but I worry that if we can't make it practical and can't demonstrate its value-adding capability, then it may not actually get traction. Next slide, please. In phase 2 of co-value, Forcino and colleagues have reported on some emerging domains of value creation in co-production. And some of these are different than what we might see in traditional quality concepts, things like communication and interconnectedness. And others that have emerged are ones that we're more familiar with, like access and cost. Note also, though, that a major domain that has emerged is health professional experience. And that's an interesting one to note. Next slide, please. The previous presentation really touched upon this next area, so I won't elaborate on it too much because I think it was very well stated. There is so much potential benefit with future technology, but health services research is going to have a critical role in studying it and helping to move us towards the use of beneficial applications of artificial intelligence. As a practicing clinician that still struggles with many aspects of the electronic health record, I thought the reference to electronic health records made previously is right on target. We have to make sure that these new technologies are going to make things better, easier, faster, safer, and more, I would argue, more humanistic rather than more mechanistic. If you can hit the advance, we'll bring up the part that was also alluded. Advance 1, please. This can go down the wrong road if we're not careful. It could make work harder. It could, over-reliance on algorithmic thinking could lead to harm that could be avoided. If our algorithms aren't inclusive, we could increase disparities. We could generate more cost, and at the worst, it could be manipulated for commercial gain at the expense of public outcomes. Next slide, please. The next critical element I would argue we need to think about carefully is workforce. I think we'd all agree that without a workforce, we don't have healthcare. And my prediction, and perhaps this is a hypothesis and will need to be tested as we move into a technologically advanced future, I would assert that no amount of technology will replace the workforce. It may help and assist, but we're still going to have to worry about the workforce. And if we want a workforce in the future, we're going to have to think about studying it and nurturing and supporting it in ways that we haven't done before. And also, if we want implementation and translational science to really flourish, understanding our workforce better helps us understand the context we're implementing our great new interventions in, and may help us be more successful with that and more successful sustaining it. Next slide, please. I want to give due respect to the concept of opportunity spaces. I like Krogstrup and Briz's conceptualization of this from the public administration literature. They argue that we can have the best implementation, co-production, scientific breakthroughs available, but without the opportunity space for them to exist and sustain, those efforts could be prevented or even prevented from being successful. And this requires alignment of politics, economics, and policy to create the conditions in which we can be successful. And especially right now in these current political times, focus on this area can't be overemphasized. Next slide, please. One key opportunity space that I'm very interested in is learning health systems, and AHRQ has had a lot of experience in this area. This is the AHRQ learning health system model here. I think they've got great potential for accelerating and creating those nimble laboratories we're looking to create. But there's a long way to go. Learning health systems could, if in the ideal application, accelerate and better inform practice, improvement, education, and research, and really shorten the distance between bench to bedside. However, there's a lot of variation right now in applications across these models, and oftentimes the people that these models are trying to serve are not meaningfully connected to the learning health system mechanism that's designed to help them. And especially as learning health systems move out into the communities and beyond the walls of health systems, we have to think about how communities are meaningfully parts of the future learning health systems and how we can engage with communities in new and more creative ways. Next slide, please. I'd also like to touch upon a critically important area, and that's measurement. What we measure is what we can detect, and what we can detect helps us to learn, and what we're not measuring leads to areas where we're not able to see what's happening and may not be learning as much. And from that perspective, I'd like to just briefly touch upon a potential issue that might exist. Let's go to the next slide, please. Now, there are many value models in healthcare, and I certainly won't argue which one is best here, but I've chosen a whole system measures approach in Nelson's clinical value compass model for simplicity and brevity here. And it brings to light the relationship between value, quality, and cost, and has a number of the aspects that you're well familiar with: clinical, functional status, and experience outcomes. Since this talk is focused on experience, I'll just indicate that the CAPS work and CAPS metrics would fall into the experience domain. Next slide, please. When I looked at the participant list, I said to myself, I've got to ask them a question because there's so much expertise here. I'd like to see what this group feels. I'm going to do a brief poll question. In your experience, which measurement domain is least often measured in health services research? And you got to choose one, and there may not be one right answer here, but vote for the answer you think is right. I think in the interest of time, we're going to close it fairly soon. And if it's possible, could we close it and show the results just briefly? Very interesting. So we got a very interesting distribution here. And interestingly, I didn't see experience on the list. That was one of the ones we wanted to see, but we're showing that there's quite a bit of diversity of opinion here. So we can close that. Thank you very much. I'm going to, if we can go to the next slide, please. Just talk about one possible answer to this, which argues that it might be experience, and especially in the learning health system literature. We can advance it one to bring the circle up to show experience. In a recent bibliometric review of the evidence on learning health systems, they found that most of the work has been done on the mechanisms and data pathways in learning health systems and very little about the people that they're interfacing with. So there's a great opportunity here and perhaps a call for us to include a little bit more on the assessment and inclusion of measuring experience in the work we do. Next slide, please. I really appreciated the fireside chat comments this morning and wanted to comment that many institutions are trying to work on creating this new capability for the future to create perhaps a flexible and nimble lab that is able to execute at the health system level to help move health services research forward in a more integrated fashion. And this is our promised co-production learning health system, and it's under development. Certainly is not perfect by any means, but I wanted to focus on a number of things. Its executive director, me, is actually an embedded learning health system scientist functioning in a senior leader role also in the health system. So it's an attempt to bring this management and science thing together. We've got embedded learning collaboratives that are ready to that are pre-existing, that can be mobilized to move innovations forward. Virtual peer networks, I think, have a lot of capability, especially in supporting communities and engaging with communities in new ways. And we've intentionally connected them with our training programs and with our translational science programs to try and reduce the siloing between research and practice. So this is just one approach, and we've put the co-production philosophy at the core, investing in the belief that the relational and humanistic nature of research should be at the center of what we do. Next slide. I'm going to close my comments with this human experience aspect, which is I was thrilled to be asked to come. It's like, oh, somebody read the editorial and thought that human experience was important to think about, and I certainly do, of course. But I wanted to bring it into the equation and encourage us to think about it. The work of the Barrel Institute has helped to define the field of human experience, and their Barrel's ecosystem model and human experience framework are something that I encourage us to think about. And human experience is about the experience of patients, families, and members of the healthcare workforce and the communities they serve. So it's about the people that are involved in the work. And this was influential in our recent strategic plan reconceptualization a few years ago, so much so that we changed our name from patient experience to care experience, recognizing the humanistic importance of the workforce, the people in the workforce. Now, we also recognize the associations with quality and safety outcomes. As workforce outcomes improve, they often see bumps in quality and safety, and the same thing with patient experience. So we need to focus on all together. Next slide, please. Co-production and quality 3.0 thinking, as well as the work in human experience, has moved us towards perhaps, and encouragingly, a more humanistic future of envisioning quality and safety. And we're starting to think about making value arguments for including human experience in healthcare, and that there may be more value in moving from transactional or delivery-based practice to relational or co-production-based practice. Now, a little thing at the bottom that I put in, a likely reality is that we're going to need both. I don't think it's one or the other. We'll likely need both, but knowing when to do either one might be of interest as we think about designing learning health systems of the future. So I'm going to close now with the last slide. Next slide, please. This is my what if slide, and I'm hoping this some of this might help us in our discussions later. What if including human experience more meaningfully in health services research served as a criterion check or core outcome measure when we consider new interventions, developments, and technologies? What if including more about human experience helped us to better assess context, better implement new interventions, and more effectively sustain them? What if including human experience would move us forward in ways we haven't been able to before in health systems in increasing patient experience? What if doing so would help us to better engage our workforce, empower them, and retain them? What if including human experience could be part of how we understand and improve what we currently call co-design and co-creation, and what we currently call community engagement? What if including human experience would help us to better assess and improve equity, inclusion, and belonging? And of great interest to me is what if including human experience could help us to generate the second generation of learning health systems that are humanistic rather than mechanistic, and can better serve the people that they're created to take care of. Next slide, please. So now into your agenda, and then I'll hand back off to the to our moderator. Next slide, please. I'm really delighted that the breakout sessions you have are going to touch upon these concepts. We're going to talk about co-design and co-creation and optimizing implementation and new settings and modalities of care and partnerships with people and organizations that we haven't done before, and how we can use technology beneficially to accelerate our progress and integrate all of this with efforts in economics and policy. Next slide, please. If there's one thing I could impress upon you, is this statement. In my humble opinion, as a researcher working alongside with you as a scientist, or as a practicing clinician on the front line, or as a health system leader trying to make things better, I believe strongly in this statement. Now more than ever, we must focus on people. I think that if we keep them at the center and get that right, the rest will follow. Thank you very much for having me with you today. It's really an honor to give a keynote to this really illustrious group. Thank you very much.
Awesome. Thank you, Dr. Oliver. Amazing and engaging conversation. And I was tracking chat, very active going on there. So what I'd like to do is pull in a couple of questions here. One, as I was kind of going through chat, and a couple others as I reviewing your some of your work as well. One of them though that came up is really looking at the patient and family component of that, right? So some of the comments were around patient and families really producing a lot of the care, often uncompensated. And so, but one of the questions comes up is, are we really equipping our patients and families to co-create with us? Are they ready for that? In some ways, have we designed the co-creation space in a way that makes it really easy for those folks to be a part of that co-creation process?
Excellent question. And I would say my opinion is right now that we're not there yet, but there are small pockets of places where they're getting it right. I'll share an example. Like when I was in fellowship training, I was the first nursing postdoc fellow in my region to be part of the VA Quality Scholars Fellowship Program. And they're like, oh, we'll get nurses into the fellowship program so it could be interprofessional. And they just threw us in there. And we quickly discovered that without preparing us for that, it made it a lot harder for us to actually be interprofessional. We didn't know how to do that. And over time, we learned together, and we've been able to help the next generations as we get more fellows. But I think the same challenge faces meaningful participation of family and patients. We have to compensate them because many of them don't have extra free time, and they might take time away from work to do this important work with us, and also meaningfully involve them, not only in terms of the role, but also in terms of presence. It's not okay in a 12-person working group to have just one patient or family member. We need equal and representative capability. And also, if we're going to put them on committees that are going to drive management decisions, they have to have real voting power. In the Dartmouth health system, we did something a bit controversial in our culture. We gave an equal number of patients full voting rights on a major system committee for care experience, equal to the managers. I think the future is probably going to entail having us take steps like that to not design things for patients, but design them really with patients, with an equal voice at the table.
Yeah, no, I love that. I love that approach. Operationally, it is possible. Sometimes you just have to. I think there may be folks, and I've spent a lot of time on the senior leadership side as well. We may have to let go of some egos a little bit so that we can actually have those true engagement approaches that you've described. One other question as we get tight on time here that I did wanted to ask you. So I'm in technology, right? And one of the tech implementation
and one of the tech implementation
mantras is that we quote this mantra: people, then process, then the technology, right? And so that's how you implement these technologies. That's how you do it at least best practice. Is there a health services equivalent to people, then process, then technology that could serve as a framework potentially for the future of health services research?
I think there are many promising possibilities, and some were even mentioned in the chat. And one of the breakout sessions is going to be talking about co-design and co-creation. Human-centered co-design and co-production based approaches, I think, have great potential. I think there's a lot of study that needs to be done to figure out which ones might be most efficient and effective and in what settings to employ them. So I think human-centered design has a lot of potential, and also persona-based design, which I think we're going to hear a little bit more about later. So I don't want to talk too much ahead of the next presentation, but I think things that intentionally start with the person and end with the person are likely the direction we need to go.
Absolutely. Well, outstanding. Thanks again for your time here and engaging the group and really setting the stage for the next bit of work here that we're going to jump into. Thanks again. Just a perfect component here.
It's a pleasure. Thank you.
Absolutely. So let's take that to from that. Let's jump into the next part of the day. We're going to move into our panel discussions, but we want to set the framework for the next set of discussions. So let's start with the summit vision, and then we'll move into a little vignette. So the vision here, you can read it. I'll go quickly here. The vision for the summit is to envision a future. There's a focus again on the future with equitable and person-centered healthcare systems that hold the human experience at the core of healthcare transformation efforts. This future has patients, caregivers, communities, and clinicians engaged in the co-design of healthcare interventions. The technology of this future supports and empowers patients and the workforce. There's seamless sharing of interoperable real-time data, but there's also respect for data privacy and autonomy. There's equitable access to high-quality, evidence-based care. So that's the vision for the future that this summit is framing up. With that frame, let's talk about a vignette that, again, it'll get you as you engage in the next set of conversations in the frame of mind that we really want to push this whole day in, right? So here is the vignette of the future, the year of 2060, 35 years into the future. You have a Zennial woman born in 1980, 80 years old at this stage, lives in an urban neighborhood, 49-year-old daughter. Her daughter's husband and her two middle-aged kids are who she lives with. Her Zennial husband is several years deceased. The Zennial has type 2 diabetes and hypertension. She gets by somewhat independently within her daughter's home, but it's hard to get up the steps and around town. In recent months, she's had some troubles with her vision, but she's not discussed this with her daughter or any of her multiple doctors, even though it's becoming increasingly difficult to do certain things. She has a community primary care provider whom she identifies with, but utilizes a different system at a large academic institution for all of her kind of various specialty care. She gets her labs and imaging done at independent outpatient centers, excuse me, and tracks her various appointments with her electronic device. Her daughter and son-in-law work full-time. Her grandkids are active in sports and after-school activities. Her daughter has a challenging disease herself and receives treatment for it, as well as for an anxiety disorder. She's the primary parent for her school, for school sports for her kids, and is present with her mother at these medical visits. The Zennial's daughter herself is overdue for several recommended preventive services and screening, but is not overall concerned about her health. So that's the vignette, again, kind of thinking into the future and framing that out around health services research. So what we're going to do, our next theme. So again, keep in mind the summit vision and this vignette, and then let's hold that as we move into this next session. So the next session is a panel that we're going to hear from our subject matter experts who's going to give brief presentations on different topics related to healthcare delivery. Once they've given their presentation, you can raise your hand. You can use kind of the Zoom raise hand function. And then after that, so they'll give a brief presentation. We'll have a brief amount of time after each presentation for questions. And then we'll actually have a little bit more time for questions for all the panelists. You can see the panelists here, and again, all of their bios are in your kind of packet that you received before the day. But we have Arimali Sarkar, we've got Bo Kim, we've got Enrico Castillo, we've got Cindy Escobar Alvarez, Julia Adler Milstein, and Jessica Mulligan. All are going to spend some time speaking about specific components of healthcare delivery and then again we'll take some time for questions. Why don't we so why don't we just jump right in, right? So let's start with Urimala. So Urimala, you're gonna jump in with the topic of healthcare settings and modalities of care, correct?
Correct.
Awesome, it's your show.
Thank you. It's so nice to be here. Thank you, everyone, for having me. I'm a general internist and a professor of medicine at the University of California in San Francisco, and I practice at San Francisco General Hospital. Edmondo tasked me with focusing on how we could utilize new tools like digital, mobile health, and social media platforms to improve the safety and quality of outpatient care. And I'm going to take this vignette and talk through how I think the management of the chronic conditions that came up in the vignette relate to these type of innovative care delivery models. So first of all, I think the vignette demonstrates how management of chronic conditions requires a formal and informal set of healthcare and caregiving ecosystems that are all deeply influenced by the structural determinants of health. The conditions mentioned of type 2 diabetes and hypertension both have prevalence and outcomes that are subject to significant racial, ethnic, and income disparities. In the vignette, we noted that a decline in function was really unknown to the formal healthcare providers for the patient. There is that disconnect between community primary care and academic subspecialists that remains prevalent despite a revolution in communication technologies over the last 20 years that I've been a physician. And this vignette also highlights the caregiving burden of both elders and children that is becoming even more of a pressing issue with the graying of the population. We have a middle sandwich generation that is increasingly facing their own chronic illness and double burdens of caregiving with children and elders. The challenges of remaining healthy while caregiving really cannot be overstated. There is a tremendous amount of service that is being done in an unpaid manner by caregivers. And if those caregivers are not able to caregive, that is a real domino effect in reducing health throughout our society. And this potential for negative spiral of health within a family is something that really came out in the vignette. So highlighting all of those considerations, where are opportunities where innovative technology and communication approaches could help? Okay, we can think about remote monitoring. So remote monitoring does not have to be very complicated. We've had home blood pressure cuffs for many, many years. But that idea of using devices where patients are, right, either with the computer in their pocket, right? We know that even 90% of people in this country on Medicaid actually have a smartphone. So smartphone ownership has expanded so much that really almost everybody does have a computer in their pocket. And using that or using other simple devices to provide real-time personalized feedback delivered with patient-centered communication is only becoming more possible. AI-enabled information delivery is really gone from potential to reality in the last couple of years, where we can take all of the data that comes from remote monitoring. A big obstacle has been that physicians actually nobody can use all that data. Now our algorithms have developed to the point where you can think about processing large amounts of raw data in an automated fashion to deliver the right information to the right person at the right time. And this has the potential to really revolutionize chronic disease management in a way that is very patient-centered. With the widespread implementation of electronic health records, there is an opportunity. I would say it's still a somewhat unrealized opportunity to integrate data from remote monitoring into clinical workflows and systems. And looking at self-management support, things like tailored reminders for medication, exercise, and self-management have been shown to improve behaviors. And simple technologies like SMS messaging can be harnessed to encourage the kind of positive health behaviors that really can make a difference. In terms of patient-provider communication, the idea of an easy-to-use patient portal to connect with a trusted primary care provider, that is not a technological, there's no technological gap. It is really a regulatory kind of a implementation gap that we're facing in allowing the daughter, in this case, to send wouldn't it be amazing if the daughter could just send a text message without going through a login process that was cumbersome and having to wait for a long time, send a text message to the PCP that says, you know, I think my mom's not thinking as clearly, she's forgetting things. I feel like my patients, caregivers would message me a lot more if it were as easy as sending a text message. And the barrier to do so is not technological. Furthermore, there are diagnostic tools like apps that are available right now that can be used to check vision. Again, harnessing that computer that people have in their pocket. So we're getting to the point where not only are we doing communication more seamlessly for patient chronic disease management and self-management, we're actually thinking about how can we use the connected environment around all people to actually make diagnostic and therapeutic decisions. I want to end by saying a word about social media. That is an area that I have studied that has really mixed effects on health. But when I heard this vignette that Edmundo had sent in advance, it actually made me think of one of my patients, who is a 50-year-old Spanish-speaking woman who cares full-time for a parent with pretty severe dementia. And this person is in a low-income group and is availing herself of a local program we have in San Francisco where family members can actually receive funding from the city to do caregiving because it keeps people in their homes. And I was talking to this patient who has quite severe hypertension and diabetes and extreme caregiver stress about how she manages her caregiver stress. And she told me that if her parent with Alzheimer's is severely agitated at 3 a.m, and then she finally gets her settled back into bed and she's activated and now she herself can't sleep and feels very alone, what she does is she goes to her Facebook group, which is in Spanish, for Alzheimer's caregivers. And she knows that someone else is awake at 3 a.m, having just spent 2 hours calming a person with severe dementia down. And that person gives her words of support and maybe says a prayer with her. And that is her support. It can be asynchronous or synchronous. It is 24/7. It is free. And it does not require engagement of anyone else. So despite the many challenges of social media, it is a communication technology that we can use to intervene in these health and caregiving ecosystems that we're all living in. I will stop there. Thank you so much.
Awesome. Thank you, Dr. Sarkar. So so love that example that's tying the vignette together. One question for you is with all of that, you know, you're bringing the digital components in and the caregiver components in. What's the role of AHRQ in, especially in this? You think about this future, right? And what's the role of even bridging to that future, so that we really can realize the potential that you're describing here?
Yeah, I think that I asserted several times that I don't think the barriers are actually technological, right? I think we have a lot of implementation barriers, and I would love to see AHRQ support more implementation research. I will candidly say that I think that our study section members at AHRQ are very innovative people and are often looking for something that's very cutting edge in terms of technology. And I would gently suggest that perhaps we should be thinking about utilizing the technology we already have to close these innovation gaps rather than pushing on what newer, shinier technologies are possible.
Yeah, no, that's a really great point. Thank you again. Great. So, and we'll go to our next panelist, but for the folks on the call, we will pull everyone together, and we'll have some time for questions at the end as we march through. So, thanks, everyone. Let's go next to who's next on the list? Oh, Bo Kim, you're up. Optimized implementation of health services research.
Thank you very much. And Dr. Sarkar, thank you so much for mentioning the encouragement to increase AHRQ's focus on implementation research. As an implementation researcher, I feel so happy to hear that. And thank you for connecting so smoothly there for us to what I'm about to say. So thank you. And hello, everyone. It's truly an honor to be here with you all today. Once again, my name is Bo Kim. I'm an investigator at the VA Center for Health Optimization and Implementation Research and an assistant professor of psychiatry at Harvard Medical School. Today, my prepared comments at their core are really about emphasizing the strong relevance, I guess, of some of the key concepts already discussed during the presentations earlier today to really the relevance to implementation of evidence-based practices. And I hope the emphases can really serve as a springboard for us all to be able to consider those concepts in light of the vignette as well. So in particular, I wanted to bring to your attention the interrelationship between several of the components that were mentioned earlier today, specifically three key themes that I feel are central to really advancing implementation efforts in healthcare and related social services, of course, as well. So they are, in my mind, context-aware implementation of evidence-based practices, equity and justice-related considerations when it comes to that, and the evolving role, of course, of technology and in shaping those efforts. So each of these components, I think, really plays a very unique role in ensuring that interventions are both effective as well as equitable. So talking first about sort of context-aware implementation. So evidence-based practices, or EBPs, don't operate really ever in a vacuum, right? So the context such as organizational culture or patient population, local policies really affects whether and how these practices can be integrated and sustained. So traditional sort of one-size-fits-all models we have found to often fail because they've missed the nuances of real-world settings, and by therefore sort of employing a context-aware approach, we are able to then adapt EBPs to align with specific environmental as well as related social factors. And then hopefully that is a way in which we can increase their relevance and effectiveness as well. So this really involves sort of a continuous cycle of assessment, adaptation, iterative refinement. I think it relates a lot to the LHS or learning health system concepts that were mentioned earlier today as well. So then thinking about equity and justice considerations. So implementing evidence-based practices must, of course, go beyond just contextual relevance, right? It must also focus on equity and justice. And historically, as many of us are aware, many interventions, I think, have been designed and tested within quite limited populations, often neglecting marginalized groups. So a focus on equity means ensuring that every aspect of implementation really considers the differential impact on underserved communities, addresses structural barriers, and being able to really prioritize, therefore, inclusive engagement. And this isn't just a matter of fairness, I think. It's really about making sure that the care and the research that we do as well, that we really implement ones that achieve full impact, regardless of a patient's background. And then so now bringing the technology consideration into this, technology acts as both a facilitator and, as mentioned earlier, too, sometimes, unfortunately, a disruptor in implementation efforts. So on one hand, digital tools like AI, as we were talking about earlier, machine learning, data platforms, things that we're becoming very used to, I think they allow for real-time monitoring, predictive analytics, personalized adaptations, let's say, of interventions. So, for example, implementation teams can really leverage dashboards that display context-specific performance metrics, helping them make evidence-informed adjustments very swiftly, much more so than before. So there's that. And then on the other hand, technology also introduces new challenges, such as digital access disparities, I think is a really big issue. Biases and algorithms, as was mentioned earlier, that may really perpetuate and often unintentionally perpetuate existing inequities as well. So what happens when we sort of integrate these three themes is what I would be very much interested in thinking together with you all about. So consider a scenario, let's say, where a healthcare organization aims to implement a collaborative chronic care model. A context-aware strategy ensures that local resources, for example, or patient needs, and then organizational dynamics are all factored in. And then beyond that, an equity lens will really be able to prompt the team to examine whether the patients from historically underserved communities are equally benefiting from that intervention. And then technology then is able to enable continuous monitoring to detect disparities in outcomes and iterate improvements in a swift manner. So addressing sort of context, equity, technology in tandem, I think it isn't really optional. I think it's really, really essential. And so to be able to advance meaningful implementation, we must embrace these sort of interconnected dimensions, I think, aligning our strategies to adapt to unique contexts, help this eliminate disparities, and then by leveraging technology responsibly in that way. So I think that brings me to the end of my prepared comments.
Outstanding, outstanding. Thank you, Dr. Kim. So, I love this. I love this framework that you described around the context aware, right? The equity and justice, the technology, and as I think about, this idea of really the uptake of evidence-based practice, and really, it actually goes a little bit back to what Ramal was saying. It's like we have good technology, for example. Yes, new technology is coming out, but we're not using the stuff we already have very well. So I bring that back to the framework you described with the context aware and the equity and justice in tech. What's the role of health services research in getting us to the point where we actually are much more adept, let's call it, at really leveraging those concepts in that framework you described?
That's a really, I think, important question. So in terms of the research aspect, I think sort of enhanced measurement and evaluation methods come to mind. So being able to advance metrics that are specifically capturing the impact of some of these implementation strategies on equity outcomes, let's say, or sustainability, I think will really help refine the quality as well as sort of the scalability of the interventions. And so those metrics, I think, could really assess long-term outcomes, for example, like disparities reduction and adherence to, I guess, really culturally sensitive practices as much as possible. So that may be the first thing that comes to mind for me. I would be very much interested in hearing other suggestions from everyone here as well.
Yeah, no, I think that sounds great, and agree that we want to pull other options and opportunities again as we think to the future, the next 35 years. I think that's exactly what we want to do. Thank you again for your time. Appreciate it. You'll stay on the line as we move through the panelists and pull everyone back for general questions. Thank you again. Let's bring on Enrico Castillo. And hi, Enrico. So you're going to be talking about intervention, co-design, and health services research co-creation, yeah?
Yes, that's right. Great. Yeah, thanks so much. It's a real honor for me to speak with you all today. I'm Enrico Castillo. I'm a mental health services researcher, community psychiatrist at UCLA. I focus on community partnerships, homelessness, serious mental illness, and generally on increasing the capacity of research and systems to address health and social inequities. So as was mentioned, my topic for the panel is intervention co-design and evidence co-creation. How can we better work hand in hand with diverse communities and enhance the capacity of our research to address inequities? And I was really moved by Dr. Oliver's keynote, and I may be echoing and emphasizing some of the points that he made. So in reflecting on this topic, I came across a story that I thought was very poignant and relevant. There was a train station in a small town in Japan that had only 36 residents. And the local railroad company planned to close down the station because it was becoming unused. One analyst, however, they noticed that there was a high school student who boarded the train every morning. One student. She traveled 35 minutes by train to school, and then she did the same in the afternoon to return home. And the railroad company decided to keep the station open at a financial loss for 4 more years until the student graduated, because they understood that closing the station would cause her significant hardship. And I think that there are so many lessons that we can take away from this story. This is a story about access to services, in this case, a train station. It makes me think about our patients and our communities. You know, how many of our patients and how many communities in America are waiting on a train platform for a train that'll never come. And in thinking about health services research, what it could look like in 35 years, this story made me think about the ways that I hope our American culture and our priorities as a field will change in that time. So over the past 3 decades, you know, in my view, health services research has focused heavily on establishing its rigor, statistical significance, evidence-based services, algorithm-based care, high-fidelity practice. But in our pursuit of technical expertise and generalizable data, you know, data that can be used by anyone and in any community, I feel that we risk losing something, namely our connection to individuals and communities, especially those that have been marginalized and are marginalized by science, you know, whether by race, gender, sexuality, religion, disability, poverty, stigma, or other reasons. So in the next 35 years, I hope that our field embraces connection and context as much as we value fidelity and generalizability. You know, I recently read a review paper where the authors explicitly excluded studies. They excluded them that were focused on specific minority groups or cultures in order to make their findings widely applicable. You know, they dismissed racially or culturally adapted interventions as too specific, you know, too niche, and therefore not generalizable. But the truth is, you know, our world is diverse, and we know that context matters in health, as has been mentioned. I feel that we can create knowledge that's both broad and specific without sacrificing the needs or the perspectives of minority groups. You know, specificity is not a weakness, it's a strength. And our connections to individuals and communities are a powerful asset, not a liability. You know, so looking forward, I hope that we're in a place in American culture and in our research where we can embrace the needs and the voices of marginalized people. I hope we can see a future where it's no longer illegal, it's no longer taboo to dedicate our careers to issues like diversity, equity, and inclusion, racial and social justice, LGBTQ health and gender affirming care, gun violence prevention, and improving the social safety net. You know, these are the issues that when addressed can improve the lives of those who are most vulnerable. So in talking about intervention co-design and evidence co-creation, of course, it's crucial to talk about community partnerships. You know, who's at the table? Are their voices included? Are we centering community knowledge and expertise alongside of that of the academy? And also, it's really important to examine what incentivizes our fields. You know, our partnerships, equity, justice, community impact, are those built into our university promotions and also funding priorities? But I think what's foundational and perhaps what's harder to talk about is connection and trust. So in the next 35 years of health services research, I hope we spend all of that time bringing our science and our scientists closer to people that our research has left behind. I hope that we shift research funding toward under-resourced areas like sickle cell disease and the WHO category of neglected tropical diseases and other illnesses that need more funding. And I also hope that researchers are as likely to bring their findings to the community as they are to academic conferences and peer-reviewed journals. In 35 years, I hope that our nation has come to understand that we're all connected, that the voice of the individual is as valuable as the voice of the many. And I hope that we recognize that providing more to those who have less doesn't diminish us, but makes us whole. And as a research field, I hope that we view our research as a calling, as a public service to heal not just the diseases of the body, but also the inequities in our laws and our systems and our society that cause illness. So fundamental questions, in closing, fundamental questions we must ask ourselves as a field and as individual researchers are we truly connected to the people that we serve? And are we trustworthy enough to engage in the work of intervention co-design and evidence co-creation in a way that reflects their needs, their realities, their lives? For me, connection and trust, they're the very foundation of meaningful change. They're the quiet everyday work of listening deeply, being there for people consistently, and making sure that no one's left waiting for a train that'll never come. So in the next 35 years, I hope we make that decision to build connections and trust as a foundation for intervention co-design, evidence co-creation, to ensure that our work makes a real impact on the communities that we hope to serve. Thanks so much.
Awesome. Thanks, Rico. So one question that's great, and I do like the way you tied it back to the keynote. That's amazing. One question, because you didn't have the slides ahead of time, so you actually did that on the fly, which is great. One thing that comes as you describe that, right? So part of what I'm thinking about is how do we get there? Right. So what are the ways, especially because what's been happening in the chat is this idea of engaging with patients, families, communities, right? So part of what you're talking about, if we're going to be able to have that world that you're describing in 35 years, what facilitates our way to that future? Like you can just describe me, a couple of bridges to that future if you can.
Yeah, absolutely. So I think what I would recommend is I mean, the chat has been incredible. You can see these amazing, tried and true frameworks, things that people are doing, evidence-supported frameworks for community engagement, intervention co-design. But, one thing that I would just say is that if you're a researcher or a research group, is find a community-based organization in your area and talk to them, as a first step. Frameworks can be really helpful, but it's really important to, operationalize it. So talk to them, meet them at their office, get to know them better, share your work, but learn about what that community-based organization is doing, and then offer your services to them. And then also the same thing with systems leaders, city council members, a mayor's health deputy, state representatives. Go to them, meet them, learn about their work, learn about the things that are on their constituents' minds, and how you can offer your services to them. And then you can apply the evidence-based framework. But for many of us in the audience, those kind of practices are familiar to us, where they're very comfortable. But for many health services researchers, that can be very forbidding or feel alien. So I just encourage people to build that muscle, to start talking to people.
Yeah, no, amazing. Yes, exactly. It reminds me of the community-based participatory research that I was trained in as well. So thank you very much for your time. We're gonna keep moving here and try to keep on time as much as possible. Thank you, and you're gonna stay on as we pull up questions at the end. Thanks. And Bob Brook, I do see your hand. We're gonna pull questions up at the end of our panelists so that we can give everyone enough time. Let's bring on. Let's bring on Cindy now, I think is next, if I have my list correct. Yes, Cindy, you're up, and you're going to be talking about partnerships that support a robust health services research enterprise.
Absolutely, and thanks for having me in this panel. Good afternoon. I am a biomedical scientist who's working in philanthropy for over a decade. So specifically at the Doris Duke Foundation, which aims to build a more creative, equitable, and sustainable future. So not as an expert of health services research, but fairly steeped in health research and partnerships as a funder. So happy to speak to what would make for good care for the Xenial scenario. And the scenario makes several assumptions, right? One is that care and research focused on outcomes for the patient rather than on areas of specialty for the individual as a collection of organs. Second, there is the assumption that there is translation of evidence into practice that is top-notch at every clinic that this person visits. The third is that technology is also centered on human experience and in the goal to provide information that can be trusted, as has been mentioned by my fellow panelists. Data sharing would be easier and owned by the patient. The fourth one is that patients and communities have healthcare literacy, right, to make their own decisions and decisions for those around them and in their community. And the last one is that patients receive the care that they need and when they need it, regardless of their condition and background, as was also brought up earlier. And so as I think of my task to reimagine how will partnerships would have helped us to get to this scenario, I think of four points here that I will go over, try to do fairly quickly. The first one is that funding agencies will have generated and aligned on an outcomes-based roadmap to improve the health of a nation. This includes governmental and non-for-profit funding organizations of health research. Second, I think the partnerships will have helped us to have governmental funding agencies be freed from their disciplinary and budgetary silos, right? Agencies would be collaborating and working with resource allocators to eliminate the importance of all forms of research to achieve innovations, not just in technology, but in health outcomes. Third, academic institutions would align with funding agencies to reward scientific careers and discoveries in health research that further the outcomes-based roadmap that we mentioned initially to improve the nation's health. So as a result, health research scientists throughout the continuum from basic to applied would also be aligned with that roadmap. And finally, I think that to achieve this best care scenario, funders, investors, and the government, for example, local governments, will have created pathways to facilitate research implementation and equitable clinical practice. There would also be an aligned push and pull mechanisms in both ends so that researchers can more easily pursue research that they think is important, that there's a clear pathway to store the research into application. And as we know, just as we know to do right now with pharmaceuticals, as was said, similar to was said earlier by Aaron Carroll. So those are my brief remarks there.
Thank you. That outstanding. And so my follow-up question based on that is right. So part of the challenge might be policy. There might be policy implications to some of the things that you're describing. So is there again, I'm gonna stay with my theme across each of the panelists. Is there a bridge to the future that you're describing that that might require some impact or influence in from a policy change perspective?
Absolutely, right. I think that as what I know most is the pathways from drugs to from discovery to drugs, right? And there is the pull is by industry. However, what I hear from health services research is that end product may be applicable at a in a hospital, but whether we achieve that homogeneity in practice could depend on policy, right? So there's such a connection to policy that I think ideally that'll have evolved, and we will have also those pull mechanisms be more clearly aligned with researchers so that researchers see where that is heading.
Yeah, that makes a lot of sense. Excellent. Thank you for your time here as well in perspectives. You'll stay on as we bring Julia up. Let me just double check. Yeah, bring Julia up next. Julia's talking about real-time data and sophisticated analytics for rapid learning.
Wonderful. Well, thank you so much. This has been such a rich panel already. I think a little bit of a drinking out of a fire hose, but hopefully you have a few more gulps left in you. So I am a professor at UCSF. I'm the chief of our Division of Clinical Informatics and Digital Transformation. And most importantly, I consider myself a health services researcher. Got my first ever grant from AHRQ now many years ago on the topic of learning health systems, and just feel that this community is so critical to be able to advance our understanding of how to use technology to improve the health of individual patients all the way up to populations. So I'm here today to speak about real-time data and sophisticated analytics for rapid learning. I'm actually going to break that topic into those three pieces. I'm going to talk first about real-time data, sophisticated analytics, and then rapid learning, because it really is the combination of those three that we need to envision together in the future. So let's start with the data piece. I'd like each of you just to take a moment to think about what data would best speak to the state of your health over the past, let's say, 6 to 12 months. So as I think about the data that would best speak to my health over the past 6 to 12 months, I would say a very, very small fraction of that would be available to a health services researcher today to really understand why I am healthy or not healthy, what contributors might improve my health. And so I think the most important part of this three topics that I'm going to speak to today is how do we pull together the breadth of data we need to really understand health at all the levels of scale for an individual, within communities, and all the way up to the population level. So if there's one takeaway from my talk, it's how do we expand the breadth of data to really understand people's health? And I'll loop back in a minute to talk about that in the context of the scenario. So Also in the topic of my talk was this issue of real-time data. And I think we all would agree that there is some issue today, even with the data we have, related to data latency. I think we experience that most directly oftentimes when we're using administrative or claims data. And we're always, in most scenarios, sort of forced to study what happened, 2 or more years ago in the past. So I do think in my framework, there's a minor issue related to data latency. And if we could figure out how to close that gap, it would have a major impact. Another issue related to data is how do we configure the large repositories of data that exist today, particularly clinical data, to better support health services research specifically? Most electronic medical record data, I think, is really best supported, is best designed to support biomedical research questions and not so much health services research questions. So even as I have gone in and said, well, my primary construct that I want to understand is the healthcare team and who is on the healthcare team, it takes a huge amount of work even just to reconstruct that foundational concept. So again, I think as we think about data, we have some really important work to do to be able to represent existing large data sets with the key structural features that help us understand how care is delivered, not just what care is delivered. So as I said, I put the latency and those sort of structural features as like important, but far dwarf is this issue of the transformational opportunity to expand the breadth of data available to health services researchers. And if we go to the scenario, I think what becomes really clear, for example, is that if we could understand the relationship between parents and children, right? That would be huge in really trying to understand what's happening. And again, sometimes for good reasons related to privacy and confidentiality, we don't want those ties to exist. But in other cases, we think that that is actually perhaps the most essential missing piece to be able to understand health and how to advance it. So that's one piece, is sort of within data, how can we structure data to be able to link relationships so that we can understand how one individual's health is impacted by another individual's health who is part of that family or community network. Another piece of it is just simply the breadth of data that we need to start to be able to link together. So I suspect as you did your thought exercise, you were thinking about things like, well, how active was I? Or what did I buy at the grocery store? Right? These are all things that exist in different forms of data, but they are largely not linked. And it is also very difficult to imagine how they could be accessible to health services researchers. A lot of times those data are considered proprietary, or the stakeholders that hold them are not part of our sort of usual community of health services researchers. So I think that is the key issue to tackle as we think about how to move towards our future state, is what structures or frameworks or policies could move us towards that wider aperture on data, how to bring them together, link them, and as I said, ideally build in this sort of family and network structure that sits around them. So that's the data piece. The sophisticated analytics piece, I have to be honest, I'm not worried about it, right? We have seen our health services researcher community be really innovative in rapidly integrating new analytic techniques as they evolve, and those techniques will continue to change. I mean, I think large language models is probably the obvious example of, the new kid on the block with respect to sophisticated analytics. And we're already seeing, a huge amount of creativity in terms of how that's being integrated into health services research techniques. So I think we can expect that analytics techniques will continue to change in unexpected ways. And I think our community seems, generally well adapted to integrate those and apply them. So then let me end with the rapid learning piece. And I think this is another area where I would really note that we need some focus. We've talked a lot about evidence co-creation, but what about learning co-creation? How do we think about the frameworks that are going to help take that evidence and help get it into routine practice? I've seen a lot of progress around within the learning health system movement around thinking about, the analytic techniques that we need to be able to push out evidence at scale. And that is resting on the assumption that evidence as it's generated can be put into a computational form. And there is clearly some evidence that will be computable, right? An algorithm is obviously the best example of something that will be computable. And so you could imagine that in the not too distant future, we might have an infrastructure where instead of an algorithm going into a paper, that then relies on someone reading it and trying to implement it, that it goes into a computational object that can then be picked up by an electronic medical record system and get to very rapid scale that way. So I think, certainly by the time, by 2060, we'll have that infrastructure in place. But I think that only works for a small subset of knowledge, the knowledge that can be, as I said, easily adapted into something that's computational and integrated then into work. What I worry a lot more about is all of the knowledge that won't lend itself to that dissemination mechanism. And how do we do rapid learning in that context? Again, I think we're seeing a lot of important opportunities, but I haven't really seen the science of rapid learning for knowledge that's not computational be well developed. So that's sort of my second big focal area that I think is really critical to get to our future state in 2060. Thank you.
Thank you. So really great, and I'm sure there's lots of thoughts, a ton of chat around data, how to build it, and moving forward. We're gonna move to our next one. You please stay on. We're gonna open it up for questions at the end. We're gonna bring Jessica on next as our last panelist in this session, and then all 6 panelists will stay on and we'll have questions. But let's go to Jessica Mulligan for our last panelist here.
Hi, thank you for the introduction. I'm Jessica Mulligan. I'm actually a medical anthropologist and professor of health sciences at Providence College, and I'm really honored to be here today. So this exercise and the anecdote we were given to think with requires us to really imagine a person-centered and equitable future that we do not currently seem on track to achieve. So I'm kind of the invitee to this party who's going to be a little negative, at least at first. So while there is an unprecedented volume of data, as we just heard about, at the disposal of health researchers, these data are generated from and processed within systems that are structured by inequality. As we well know, many of our algorithms themselves reproduce bias. And despite the tremendous gains made in patient safety and evidence-based interventions that we rightly celebrate today, we're also experiencing a number of really acute challenges, right? So we've seen in the past few years historic declines in life expectancy in the US, driven by COVID, but not just COVID, and we are recovering much more slowly than our peer countries. We see waning trust that leads people to reject technological marvels like life-saving vaccines, and too many people feel let down and left out by progress and innovation in US healthcare, as was already mentioned. We see the accelerating impacts of climate change, which are bringing economic losses, surges in morbidity and mortality, disruption to supply chains, as well as chaos that is exploited to create more distrust. And finally, the topic I was asked to talk about, financialization and economies of care. Financialization and other forms of predatory management practices drain capital from health systems and replace it with debt. So many of these issues fall outside the traditional purview of health services research. But in order to get back on track toward a person-centered and equitable future, the one we're trying to envision for Xennial, we must study health systems in their culture and economic context. And I'm really heartened to have heard that word context so frequently already today. I think that's really important. And this requires a holistic health services research that anticipates how broader economies and ecologies of care shape our health-related vulnerabilities, shape our access to care, and the quality of our health system. So looking at those things outside of the health system per se and how they're creating our possibilities. So to get back on track, I don't want to just be negative. I do see sort of pathways, as we've been talking about, towards the future. And I'm going to focus on 3 of them. I think a big one is rebuilding trust. We need to conduct research that rebuilds trust in science, medicine, and healthcare institutions. And I think there was a lot of examples and ideas in the earlier talks and in the chat for ways to do that. But participation in research can also be an educational and a civic and a co-learning experience. And when we build knowledge with the communities we serve, we also build trust. And I think that needs to be just sort of a fundamental aspect of what AHRQ is doing. We need to prioritize climate resiliency. Creating climate resilient systems that anticipate and respond to uncertainties and extreme events has never been more important. And AHRQ is certainly moving in this direction with guidance on decarbonization and convening meetings for measuring resiliency, but these efforts could be greatly expanded. And finally, I think we need to work on reversing financialization and maybe thinking more broadly about how improving the value and affordability of U.S. healthcare by making the harms of financialization more transparent. So financialization externalizes its harm through debt overload, low wages, facility closures, and supply and personnel shortages. Coming to you today from Rhode Island and very close to Massachusetts, we've seen a whole slew of hospital closures and reorganizations that were provoked by financialization, and they've really had a lot of downstream effects for the healthcare workforce and of course, patients in the region. So research is emerging about policy levers that can constrain and prevent these harms, but this is a rapidly accelerating trend, and we need multidisciplinary health research teams generating real-time evidence to inform policy. So to create a health system that can meet Xennial where she is at and support her family's flourishing, we need to recalibrate some of what we study, but also how we study it. So whether we're tackling trust, climate change, or financialization, these highly complex and multi-scalar phenomena require examination at multiple levels from truly interdisciplinary teams who take the cultural, ecological, and financial context of caregiving seriously. I'll stop there. Thank you.
Excellent. Yeah, great. And speaking of context, thanks for bringing all that context back into this discussion. That's amazing and very timely. Let's do this. If we can pull all of the panelists up and pin them all up, we're going to open it up for questions from the group for all of the panelists or any of the individual panelists, whichever you want to do. That for those questions, you can still ask the question in the chat if you're a little video shy on your questions, but use the raise hand function. I'll take a couple of questions to try to keep us on track and on time and be respectful of everyone's time here. So let's do that. As the panelists come up on the and be pinned on your screen, we'll start. The first question is Bob Brook. Go for it, Bob.
I listened to this conversation among people, and if I was Elon Musk and I was trying to increase efficiency in the government, I might defund health services research. What I listened to you all is that you have strong moral compasses and you say all the right things, and you don't seem to make a case for how health services research is going to get us there. And part of me wants you all to give up your academic job and go work for the organizations that are now actually doing the things that you tell them to do, whether it's the VA or Altamed in California. I would love to hear a case. I doubt that any of you are Republican or any of you are voting for Trump, but that's who's going to win. And the country for a number of years is going to have to convince 50% of them that health services research is worth doing. How do you translate your strong moral compass into making a case, if you had to present a case to them about how to get health services research funding to complete, given all of the things you said haven't worked over 35 years? None of you said anything about a successful thing that you did that worked. It was all about what we have to do to be successful. You're even back to going to the word trust, which tends me to believe that all the work that people have done for 30 years in community engagement that you've done hasn't gotten us very far. How do we get further than we're at? What's the agenda here to motivate people to fund us on both sides of the political aisle?
Whoever wants to take that provocative question from Dr. Brook.
I mean, I'm happy to give an example. I mean, I think that question was not the one we were asked to speak to. And so, I think if we were each asked to speak to it, like we would have been able to give examples from my own work. I think it's really been the work around interoperability. It's been a very bipartisan supported issue. And I think everyone agrees that we need to have data that's flowing, across our healthcare system to be able to deliver better care. So in sort of my 10-second response to you, I do actually think that there are examples. I'm not, I mean, I do think we'll have to raise the bar, but I do think that there are examples from the past.
Excellent. Arimala, you were jumping in too.
Well, I was gonna say, I don't think anybody in this country feels like their own personal healthcare experience they're having is optimal. And in my experience, you know, I'm in San Francisco, I have limited experience talking to people of wide political persuasions, but in my limited experience, I have found that thinking about how technology can smooth the healthcare experience is something that also garners quite a lot of bipartisan support. So I think all of our work can lean into that part of it.
Excellent. Thank you guys for the response. We'll take the last question here, Jerry Gerwitz.
Yeah, thank you. I really enjoyed the conversation and the presentations very much. I did find that they were very contemporary, the comments. And as an aging geriatrician and an aging person in America, I think a lot about the future. So in thinking about 2060, I'm thinking, okay, that's in the midst of the 100th anniversary of the baby boomers. There are going to be more 100-year-olds at that time than any time in our history. That this 80-year-old may be caring for her 100-year-old parent. That with birth rates declining, she may not have kids. So I'm trying to think, what is that future really going to look like? And will the same diseases that we're thinking about today and conditions be the ones we're thinking about in 2060? So a whole bunch of issues, and I find it very disorienting myself, so it's got to be disorienting for all of you. But I just wanted to add that context.
Yeah. So thanks for adding that context, Jerry. So the way I would think about, and to fairness to the panelists, obviously these questions are contemporaneous and we weren't prepped for them. But the way I would frame up that context, yes, we put a vignette out there. It's not the only vignette. It's not the only future, right? It's a potential future for a family, right? And there's many of those that go cut across the different experiences that people will have. The question, though, really that I would put to the panelists based on that is, what are the foundational frameworks that we should be laying down now from a health services research perspective, whether it's data that Julia is talking about, or some of the digital stuff that Ramala talks about? What are those foundational frameworks that will allow us to be successful in all of those different potential future scenarios that will manifest themselves in 35 years? Go ahead, Bo.
Thank you. So one thought that comes to mind, and I think this definitely relates to some conversations that have already happened, sort of cross-sector collaborations, I think might become, I mean, it's already, of course, very important, but increasingly so. Sort of the emphasis on kind of the sustainability and equity types of things that we were discussing earlier. I think it offers opportunities for collaborations across like healthcare, public health, social services, legal services that people might be in need for, and different types as kind of the population and their characteristics change over time. So building the basis now, being able to kind of have those structures in place, processes that we kind of as a society have practice with by the time 2060 rolls around, so that we can really strengthen those partnerships now, build on that, social support programs, really adding holistically to healthcare and address patients' needs beyond just the clinical settings, I think could be one area to really expand in.
Yeah, I like it. I think that's spot on. I'm a little bit more of a optimist than Bob Rook is, and I think that some of those foundations are being laid based on the successes of the past, with the acknowledgement that there are many opportunities to improve from where we have been over the past 35 years. With that, thank you to the panelists. We will use this time to note that this ends our live stream portion of the summit. Thanks to those in the public who have joined us. For those of you who are going to continue to participate in the summit, we're going to pause for a minute and then continue our agenda. So don't drop off. We're just gonna do a technical change here. Thank you all.
Produced by the U.S. Department of Health and Human Services.